Hello, welcome to Learn from the Case. How are you? Today I want to talk about Sleep Apnea-Hypopnea Syndrome, what I consider essential to know about this syndrome. It is said that in general, human beings spend a third of their existence sleeping. However, the reality is often unknown. Sleep is an active phenomenon in which several stages characterized by defined neurophysiological patterns are repeated. Any anomaly that alters the structure of a sleep makes it unrefreshing, and consequently, drowsiness or fatigue appear during the day, among other symptoms. Furthermore, during sleep, essentially during REM phase, there is a general reduction in muscle tone and also in the strength of the muscles that keep the upper airways open, which can lead to apneas, hypopneas. Apnea is when there is cessation of airflow in the nose and mouth during sleep, lasting more than 10 seconds. Hypopnea consists of a discernible decrease in airflow in the mouth and nose for more than 10 seconds, and it is accompanied by an oxyhemoglobin desaturation greater than 3% and or transient non-conscious awakening, arousal. The sum of the apnea-hypopnea episodes divided by the hours of sleep is called the apnea-hypopnea index. When it is greater than 5, although some authors consider 10, it is considered abnormal. And when it is greater than 30, it is considered serious. Respiratory-related arousals should also be counted as hypopneas, since both has the same origin. When apneas, hypopneas present with symptoms, the entity is known as Sleep Apnea-Hypopnea Syndrome, SAHS. When a patient has a apnea-hypopnea index greater than 30, even in the absence of noticeable symptoms, it is clearly considered an entity to be evaluated. Note, in the US, it is considered 15. In clinical practice, however, it seems reasonable to use apnea-hypopnea index over 15 as clearly abnormal. When respiratory polygraphy is used as a diagnostic methodology, it must be taken into account that the apnea-hypopnea index is undervalued, since instead of using sleep time, the time the subject is in bed is used. On average, if the patient reports having slept well, the difference can even be 5 to 10 points. Another index is the number of hourly desaturation of 3%. It is the number of time the saturation is reduced by 3%. Their values are also usually 5 to 10 points lower than the apnea-hypopnea index. There are 3 different types of apnea-hypopneas according to the current classification. Obstructive, much more frequent, which are characterized by the cessation or reduction of airflow in the mouth and or nose despite the efforts of the ventilatory muscles that fight against an obstruction located in the upper airways. Central, rare, in which the cessation or decrease in nasobuccal airflow is accompanied by the cessation or decrease in the activity of the ventilatory muscles due to the reduction in the activity of the respiratory centers, and mixed, in which the apnea-hypopnea is initially central and then obstructive. And what is the approximated prevalence? The following can be said. In men, an AHI over 5 affects 26% of the population, and AHI over 10 to 20% of the population, and an AHI over 30 without symptom can reach 2% of the population. Sleep apnea-hypopnea syndrome is a very prevalent disease that affects 6 to 8% of men. In women, 4%, especially after menopause. And in child population, between 1 to 3% suffer from this disease. The prevalence of sleep apnea-hypopnea syndrome increases with age. The risk factors are male gender, obesity. A relevant percentage of patients with sleep apnea-hypopnea syndrome are obese. Alcohol, tobacco, due to irritation and inflammation of the upper airways, depressant drugs, and body position. Some patients only have apnea-hypopnea syndrome when adopting the supine position. It is defined when the AHI in the supine position doubles the obtained with the rest of the positions. The absence of physical exercise, gastroesophageal reflux, and little sleep are factors that worsen the sleep apnea-hypopnea syndrome, and therefore must be taken into account in the treatment. There are factors responsible for the onset of apneas. Ventilation begins in the respiratory centers that generate a series of stimuli which descend through the spinal cord and are directed to two muscle groups: the ventilatory muscles that mechanically transform this central impulse, producing a subatmospheric negative pleural pressure that gives rise to pulmonary ventilation and subsequent gas exchange, and the muscles that keep the lumen of the upper airways open so that it remains patterned during inspiration. There are a series of anatomical factors such as obesity, wide neck, maxillomandibular anomalies, or the negative pressure produced during inspiration that increase the collapsibility of the upper airways and favor its closure. When the aforementioned factors prevail over the strength of the upper airways muscles, whose function is to keep it open, either because they are weak or because the centers do not stimulate them adequately, during the night, the upper airways closes. As a consequence of the repeated gasometric changes, in some patients, the centers, especially the carotid receptors, are unstable and react in an exaggerated way to these gasometric changes, and consequently, ventilatory changes that occur during the day versus the night. And here I want to say that research shows that sudden death is more common in people with obstructive sleep apnea, who are also over 60 years old have more severe apnea or have very low oxygen levels. Although sudden death is in fact very rare, it can occur, and they theorize that it is because a person's breathing does not restart after a brief pause due to sleep apnea. But personally, I think it has to do with the instability of the control centers, such as the carotids. It seems for me to be a better explanation. Obesity is a very important element that contributes to reducing the upper airway space, extrinsic compression. A particularly important phenomenon is the fact that edema occurs in the lower limbs in sedentary patients. At night, when lying in bed, they move caudally to the neck, which favors apneas. Therefore, exercise is essential in these patients. And there are also factors responsible for the end of apneas. As a consequence of pharyngeal obstruction, more and more inspiratory air force are generated until the respiratory air force itself and or the hypoxemia induced by apneas cause a transient awakening, arousal, which is responsible for the end of the apnea. This transient awakening has a disparate effect. On the one hand, it is beneficial since it induces the end of the apnea, and on the other hand, it is deleterious because it fragments the sleep, making it no longer restorative. Then the sequence of phenomena that occurs during the night in patients with sleep apnea-hypopnea syndrome causes a series of pathophysiological and biological changes responsible for the main clinical manifestation of the disease. The same cycle is constantly repeated: sleep, apnea, blood gas changes, transient awakening, and end of apnea. During apnea-hypopneas, and as a consequence of upper airways obstruction, increasingly negative pleural pressures are generated, which causes an increase in the afterload of both ventricles. Repeated gasometric changes produce pulmonary and systemic vasoconstriction, and consequently arterial and pulmonary hypertension, which can induce cardiovascular diseases. Sleep fragmentation leads to drowsiness, among other daytime symptoms. In summary, episodes of hypoxia, reoxygenation, arousals, and respiratory efforts trigger various physiological and biological reactions, and also an increase in neurovegetative activity, among others, which give rise to systemic inflammation, metabolic abnormalities, and endothelial dysfunction responsible for consequences of various clinical symptoms. Obesity is, as already said, a negative factor that aggravates the harmful phenomena secondary to apnea-hypopneas. And well, the most frequent symptoms of obstructive apnea-hypopnea are three: drowsiness and or daytime fatigue, nocturnal snoring, and apneas observed during the night by the partner, which sometimes lead to asphyxiation. These patients have frequently suffered traffic accidents, have a history of high blood pressure, and other cardiovascular history. It is estimated that daytime sleepiness is a very permanent symptom that affects around 20% of the general population, so its evaluation is very important. An easy way to assess if the drowsiness is causing problem for the patient is to ask about hinder in social life, work life, or skills such as driving a vehicle. Physical examination may show obesity, a short neck, and in some cases, retronatia or other maxillomandibular abnormalities. The otorhinolaryngological examination may reveal a small edematous pharynx and hypertrophic tonsils, as well as nasal obstruction. Signs of cardiorespiratory failure only appear when sleep apnea-hypopnea syndrome is associated with chronic respiratory diseases or very severe sleep apnea-hypopnea syndrome. Among the complementary examinations, the blood count may show polyglobulia in very advanced cases or in cases associated with chronic obstructive pulmonary disease or obesity. Chest X-ray and echocardiogram are usually normal. The respiratory functional examination may show a restrictive ventilatory alteration and hypoxemia secondary to obesity, although usually mild. In very advanced cases, there may even be alveolar hypoventilation with hypercapnia, hypoventilation obesity syndrome. Sleep apnea-hypopnea syndrome is a factor that worsens various diseases, such as chronic obstructive pulmonary disease, pulmonary hypertension, and even pulmonary fibrosis. Craniofacial, neck CT, and laryngoscopy are useful to evaluate upper airways. The diagnosis of SAHS can occur at any age, even in children, due to hypertrophic tonsils or in obese children. Sometimes the number of apnea-hypopneas can be very high and the symptoms minimal. The definitive diagnosis is established by polysomnography, which includes the measurement of a series of physiological variables during sleep. These variables are neurological, such as EEG, eyes movements, and the muscular activity of the genioglossus, which allow us to analyze sleep, its stages, and its quality, and respiratory, such as airflow in the mouth, nose, thoracoabdominal movements, and oxyhemoglobin saturation, which allow events to be classified as apneas or hypopneas, as well as whether they are central, no thoracoabdominal movements, obstructive with thoracoabdominal movements, or mixed, and the degree of oxyhemoglobin desaturation is also assessed. Other variables are also studied, such as snoring intensity, position, leg movements, and ECG. Respiratory polygraphy only analyzes respiratory variables. It can be used both at home and in the sleep laboratory. They are useful and cost-effective for diagnosis in many cases. They should be done in patients with a high probability of suffering from sleep apnea-hypopnea syndrome without associated severe comorbidity. Furthermore, currently it can be said that polysomnography should be reserved for complex cases when a sleep apnea-hypopnea syndrome is suspected in subjects with another serious illness, heart failure, insomnia, chronic fatigue, or when neurological disease is suspected. Also when the symptoms do not agree with the results of respiratory polygraphy. A polysomnography should then be performed. Oximetry, typical side-thug recording of apneas. There are two concepts. The CT 90%, that is the time that the saturation is below 90%. It should be less than 1% of the record. It is serious when it is greater than 15%, and the saturation index in 3%. Its values are between 5 to 10 lower than AHI, and from there, its degree of severity can be established. A sensitive but very non-specific parameter, since it can be altered by any respiratory disease, chronic obstructive pulmonary disease, or even obesity. Differential diagnosis. Among the most common circumstances are poor sleep hygiene, depression, periodic leg movements, or narcolepsy. Treatment. The two basic pillars of treatment are hygienic dietary measures of sleep and CPAP. The presence of other pathologies in which sleep apnea-hypopnea syndrome could be a risk factor, stroke, hypertension, diabetes, among others. Remember, the patient must be seen as the individual they are, and also remember that on many occasions, the associated comorbidities, which are very common, dominate the condition, and from a prognostic point of view, are even more serious than the apnea-hypopneas themselves. Among others, obesity, diabetes, depression, etc. The mandatory measures that must be implemented are weight loss, if applicable, daily physical exercise, sleep enough hours, avoid tobacco, alcohol, and sedatives, sleep in a lateral decubitus position, and treat if nasal obstruction and reflux occur. Mandibular appliances move the jaw forward, increasing the retropharyngeal space and preventing the jaw and tongue from falling backwards. They are especially indicated in non-obese subjects who have mild, moderate postural apneas, hypopneas. This treatment requires the collaboration of a specialized dentist. Its effectiveness varies according to different authors, basically depending on the indication criteria and the experience of the team. Maxillofacial surgery, otorhinolaryngology, advanced prosthesis mandibular are useful options in very selected cases. Surgical treatment may in fact belong to the field of action of otorhinolaryngologist or the mandibular surgeon. In uvulopalatopharyngoplasty or partial section of the palate, soft tissue operation, or maxillomandibular advancement surgical intervention, operation of the bony part, both surgical options should always be considered in selected patients with a specific alteration in these areas: retronatia, giant or hypertrophic tonsil, etc. Although, of course, there is also bariatric surgery or obesity surgery that should be considered when these patients are morbidly obese. But after this surgery, in a small percentage of cases, apnea-hypopneas may persist. But CPAP during sleep is currently the treatment of choice for sleep apnea-hypopnea syndrome. This provides oxygen through a nasal mask under positive pressure and prevents pharyngeal collapse. And with this last thing, I say goodbye today. As always, you're welcome to leave me your comments or questions. Thank you for the attention and be very, very well.